Hi, everyone. Welcome to today's seminar, Turning the Tide on Childhood Obesity. I'm Dr. Claire Llewellyn, Associate Professor in Obesity in the Institute of Epidemiology and Healthcare, and I'll be chairing the seminar today. And just to give you a quick overview of the seminar series, Public Health Voices is a webinar series open to everyone, which aims to engage with and showcase the importance of interdisciplinarity in public health research and training. And in our third Public Health Voices event of the new academic year, we'll be exploring what local and national governments need to do to turn the tide on childhood obesity. I'm absolutely delighted to welcome Dr. Oliver Mytton. Oliver is a clinical associate professor and honorary public health consultant at the UCL Great Ormond Street Institute for Child Health. He holds a UKRI Future Leaders Fellowship and is also a consultant in public health at Milton Keynes City Council. His work is primarily focused on evaluation and evidence to inform public health policies to prevent obesity through the promotion of physical activity and healthy eating. So thank you, Oliver, for joining us. I'd like to encourage the audience to submit their questions using the Slido link, which we'll put in the chat, and we'll hold the Q&A session after Oliver's presentation has finished. I'll now hand over to Oliver for his 45-minute presentation. Oliver, you're on mute. Would you mind starting again?
Thank you, Claire. Now off mute. Most people come at this issue from a particular perspective and have strong ideas about what governments should or should not be doing to tackle childhood obesity. Now, I come at this from a particular perspective as a doctor, as a researcher, and as a public health practitioner. So I'm going to start today by setting out my perspective. And then I'm going to offer some observations to set out the context for the talk today and draw out some implications for policy and practice. And then I will move on and look at solutions and opportunities for change, highlighting some good areas of practice. And then I will finish off by offering some conclusions and reflections. Now, I should say throughout my talk today, my focus is going to be on the UK. I think much of what I say will be relevant to other settings, similar settings. If there is one message I want people to take away from the talk today, it is that if governments want to tackle childhood obesity, they need to move their focus away from individuals towards the environments and contexts that influence children's opportunities to be active and to eat well. So I started my working life as a doctor. You learn many things as a doctor, and one of them is the focus on diagnosis and understanding why the child coming to you in the clinic that day is unwell. When I moved to public health, I was encouraged to step back and have a different perspective and look at a population as a whole, the bird's eye perspective. And the question then shifted away from being, why is this individual child unwell, to why are there higher rates of illness in a particular population? And that may seem like a small and unimportant distinction, but I think it's very important. And personally really helped me think much more critically about this distinction was the eminent cardiologist and epidemiologist Geoffrey Rose, who is based at the London School of Hygiene and Tropical Medicine for a large part of his career, not far from here. He studied cardiovascular disease, which is a very much more serious epidemic than it is today, with a particular focus on prevention. And Rose was very interested, almost obsessed with curves like this. And this curve here shows the BMI distribution. BMI is body mass index. That's a weight upon height squared. And this is the BMI distribution for boys in 1990, aged 10 to 11 years in the UK. And we can see several things about this graph, like most boys somewhere in the middle around 15 to 17 units, and there's a few at either ends of the spectrum. And as you're probably familiar, higher values on the BMI curve are associated with higher levels of body fatness or adipose tissue. And I've put on this graph in some ways what we might consider an arbitrary line here at the threshold. And if boys to the right of that line, they'd be classified as living with obesity. Now, from an individual perspective, the question arises if a child is in clinic is, why is this child living with obesity? And that's effectively asking a question, why is this child different to all the other children? And when we're asking that question, we get drawn down an individual track and the answer will be framed around genetics, individual behaviours, and possibly some unique environmental characteristics for those children. I'm now going to show you a different curve in red here. And this is effectively the same population, but 30 years later, again, same age, boys aged 10 to 11 years. And we can see that curve has changed. It's kind of pulled to the right and it's changed in shape. And as a result, you can see many more boys are to the right of that grey line. And here, from a public health perspective or a population health perspective, we're drawn to or can ask a different question, which is, why are these two curves different? Why have these curves changed? And the question we're effectively answering now is, why are many more boys today to the right of that line or living with obesity than they were back in 1990? And the answer to that question will be environmental in origin. Now, Rose went a step further, and he suggested there could be two approaches to prevention. There's an approach which we're all quite familiar with, the individual medical approach. We identify people or boys to the right of that line above a certain threshold, and we offer them tailored treatment and support. But Rose also identified a second approach, which we're probably less familiar with, what we might call a population health approach or a public health approach. We're actually seeking to shift that curve to the left or shift it back to where it came from. So my perspective or my contention is that for governments to effectively tackle childhood obesity, they need to lean much more into this public health approach and a focus on the environment and much less on the individual approach. So that's my starting point. I'm now going to move on to part two and some observations to inform policy and practice. So first up, despite how this issue can be portrayed, this is primarily an issue about children's health. Generally, the issue has much better cut through when it is framed around children's health than around obesity. I have noticed there can be a tendency to assume that childhood obesity does not have any impacts in childhood. I don't believe that's true, and this slide goes some way to speaking about some of the impacts that are realised during childhood. There are two diseases here that particularly catch my attention, and the first is type 2 diabetes. Now, when I was at medical school, I was taught that type 2 diabetes was exclusively a disease of adults. You didn't see type 2 diabetes in children. When I was at medical school, the first case reports of type 2 diabetes in children were starting to come through. Today, we see over 200 cases of type 2 diabetes in children. So that speaks to me of some very profound changes in our environment, which have led to that marked increase in type 2 diabetes amongst children. The second disease I want to mention is asthma. Asthma is common and childhood obesity are common. Now, I wouldn't say obesity causes asthma, but obesity can certainly contribute to the severity of asthma. And I don't think this gets enough attention. Given how common obesity is, it seems likely to me that there will be a significant asthma-related illness attributable to obesity. Now, a couple of other points, just whilst we're on the theme of children's health. And the first one relates to, when we're thinking about obesity, we can think about some of the underlying behaviours: eating well, being active, and good quality sleep. And the health dividend from children adopting good behaviours in those spaces will be much bigger than from simply tackling excess weight in childhood. And let me give you an example. Sugar consumption, in particular sugar in drinks, is an important risk factor for the development of excess weight in childhood. And it's also a risk factor, a very important risk factor for dental carers in childhood. So tackling excess consumption in childhood or reducing levels of sugar consumption, particularly sugar in drinks consumption, is a win for both of those outcomes from a health perspective. I still find it staggering today that in the UK, the #1 cause for children to be admitted to hospital is dental carers, an entirely preventable condition. And secondly, on this theme of children's health, one of my colleagues, Russell Viner, talks about the syndemic, or the two epidemics affecting modern childhood, and that's poor mental health and obesity. I think it's worth noting that both of those share some common behavioural risk factors: activity, eating, and sleeping, as we just talked about. That suggests to me there are opportunities for policy responses that can address both of those epidemics. But so far, at least to my mind, those opportunities do not seem to be realised or put forward by the health or public health communities. My second observation is this is also about the health of adults that children will become. Children living with obesity have about a 5-fold increased risk of living with obesity as adults. That suggests that prevention in childhood will be particularly important. Now, this poses two challenges. One is political. The time cycle to see those returns is much longer than the time cycle for politicians to get re-elected. And the other is something called discounting. And this is a natural human tendency to place less value and weight on benefits that will come in the future, and particularly benefits that will be realized a long way in the future, and preference for immediate benefits. And this plays out in two ways. Firstly, if we're trying to engage schools and parents in the prevention of childhood obesity, they're less interested because what's the immediate win? And it also plays out in terms of investing in prevention in childhood, because the benefits, if they're going to be realized in adult life, are so far into the future, the economists and the Treasury will discount those benefits very, very significantly. So the implication for policy and practice, I think, is we need to focus much more on the benefits, both health and wider social and emotional development benefits that can be realized not so much from tackling obesity, but from addressing physical activity, healthy eating, and good quality sleep. So thirdly, increases in childhood obesity over time. So let's just, we've alluded to this, but let's just look at this in a bit more detail. So if we go back to 1990, take 100 children, 5 would have been classified as living with obesity. Fast forward 30 years, that number has increased 4-fold. It's now 20 children would be classified as living with obesity. Not only that, but we've got this additional colour, this red colour coming in, and that's the number of children living with severe obesity. Now, I have noticed a tendency by government, I think local government is particularly bad at doing this, national government will also do this, to draw comparisons between places at the same point in time. And my concern in doing that is we underplay and understate the severity of the present situation. So I think when making the case for change, it's very important to draw people's attention to these very marked changes that have happened over a short period of time. Fourth observation, as this graph shows, the prevalence of obesity increases as deprivation increases. Now, by deprivation, in this graph I've used, in this image, I've used something called Index of Multiple Deprivation, or IMD, and this pulls in measures. It's a composite measure that reflects things like crime, access to green space, income. And the child population here is divided into 10 groups, 10 equal groups or deciles. And we can see as we take each of these steps from the least deprived to the most deprived, small increases in the prevalence. What is really striking is just how large this gap is. So children living in the most deprived areas are more than twice as likely to be living with obesity as children living in the least deprived areas. That is a profound difference. And I think people in my profession sometimes get slightly numb to some of these effects because we are just so used to seeing them. Not only that, ever since this data has been collected since 2006, that gap has steadily grown year upon year. Implication for policy and practice then, this is really important, tackling obesity is really important for addressing inequalities and health inequalities. So fifth observation, for children and young people, there are some important windows for observation. The one that gets the most attention is the first 1,000 days. It's a really critical period for growth and development of all the critical organ systems in the human body. And how that happens can influence later risk of health and disease. With respect to obesity, weight gain and feeding practices are thought to be particularly important for later risk of disease in childhood and in adult life. So that's the first window. Second window, and I don't think this window gets enough attention, is adolescence. Now, by adolescence, I'm thinking of the period of, let's say, from 12 to 24 years. And I think it's just worth noting that the brain development continues past the period of growth or physical maturation. And some of the brain processes, neurobiological processes important for emotional regulation and judgment, they don't mature fully until people are into their early, if not mid-20s. Now, a very strong example of the importance of adolescence for health future health throughout life is smoking. So most, by and large, nearly everyone who starts smoking will start smoking during adolescence. That suggests there's a particularly unique window for stopping people smoking during adolescence. Now, I'm not saying we have the same opportunities in terms of obesity, but I think there probably are some important and special opportunities for intervention. If we think about how children move out from the home to their own independent place of living and start to adopt their own routines around sleep and activity and eating, for example, there's a shift in influences away from the family influences and the school influences to much stronger peer influences and commercial influences. And we'll come back to some of that later. And then finally, my third window for intervention. This is data from the Millennium cohort studies. Cohort studies enroll people and then follow them up, sometimes at multiple time points over a period of time. And this was a study of babies initially born in the year 2000, and they've been repeatedly followed up with questionnaires and different measurements at different stages. And here I very simply plotted the prevalence of obesity for this age group, for this cohort as it has aged. And we can see there is a particular gap here where my eyes drawn to between 7 and 11 years, where there's a particular step up in the prevalence of obesity, and that, of course, being the primary school years. And that gradient there you can see is much steeper than what happens prior to starting school, and indeed what will be happening at secondary school. So my suggestion here is there may be some other windows which we may be able to identify taking a data-driven approach that may be particularly valuable for prevention. So part 3, solutions and opportunities. What I'm not going to do today is try and offer a comprehensive list of things that can be done or should be done. There are those lists and publications out there. Instead, what I want to do is show some examples of solutions and opportunities. And I'm going to focus on a range of factors: social, economic, commercial, and environmental factors. And in doing, I'm trying to highlight areas where progress is being made, where progress could perhaps go further and faster, but also show the breadth of activities required, highlight some of the challenges, and show the role for research and evaluation. So first up, social. We are social creatures and beings. We are influenced by what other people say and what other people do. And I want to look at social norms with respect to the first 1,000 days, where we said that weight gain and feeding practices are particularly important. So first up, pregnancy. And there is a common idea out there that women need to eat for 2 when they are pregnant. Reality is very different. Actual energy intake during pregnancy increased by very modest volumes. And according to the Department of Health and Social Care, or their research guidance, it only increased by around 200 calories in the 3rd trimester. That's around a 10% increase. Secondly, feeding. Parents are often under pressure. I remember really feeding this to feed babies and for babies to put on weight rapidly. Whereas in reality, many babies are putting on weight too rapidly in the first 6 to 12 months of life. The feeding volumes, the recommended feeding volumes from the World Health Organization, the UK Scientific Advisory Committee on Nutrition, were revised down around 10 to 15 years ago. There's been a very good study by one of my colleagues, Raj Lakshman from Cambridge, and she has shown that appropriate and responsive feeding not only leads to smaller volumes of feeds being taken, but more appropriate weight gain. It also results in happier babies. There is less reflux and better quality sleep, and consequently, happier parents. And then thirdly, eating vegetables. We tend to assume children will not eat vegetables, and to some extent there is some truth in that, but it's actually relatively easy to train children to get used to the taste of vegetables and enjoy eating vegetables. They just need multiple repeated exposures of tasting vegetables. They don't need to be big exposures to smaller exposures, and they will adapt and get used to the taste and can enjoy eating vegetables. So we have a set of norms, if you like, or expectations, and there's what best practice would tell us in terms of children's health and development. So I think some progress is being made in this space. It's good that guidance changes, but guidance changing is not enough. There's a need, and I think we see this in other areas of public health practice, patient safety, and some work done during the pandemic, to really embed some of these within professional practice, but also embed it within communities and social norms. So I think that's a place where there's scope to go further. Now, how do we know this working? We have an infant feeding study in this country. Unfortunately, it used to be done regularly, but unfortunately, it was last done in 2010. And that may give us some clues as to the extent to whether we're making progress. It's in the it is due to be or in the process of being repeated now. Now, I just wanted to finish this section by returning to some data. And this shows the prevalence of obesity for reception year and year 6, using data from National Child Measurement Survey from 2006 through to present day. And the thing I notice here, and I don't think this gets nearly enough attention, is reception year prevalence is pretty flat. And given the general narrative around childhood obesity worsening, I think that is a good thing and something we could or should be doing more to celebrate and recognise. I'm sure we'd like it to come down, but at least it's not getting worse. For year 6, we see a different trend, and things are continuing to get steadily worse. That green line is on a slow upwards trend during that period of time. Now, ignore all these little blips that relate to something that happened around 21 and 22. They have subsequently largely normalised. So for me, this raises an intriguing question about why we see this difference between reception and year 6, a flat trend and an increasing trend. Now, the drivers for those 2 year groups will be different. The reception year group will be much more influenced by home factors and what's happened in the early years period. The year 6 group will be much more influenced by social factors, peer factors, school factors, and to some extent cultural factors. Next up, economic.
Mr. Deputy Speaker, I'm not prepared to look back at my time here in this Parliament doing this job and say to my children's generation, I'm sorry. We knew there was a problem with sugary drinks. We knew it caused disease, but we ducked the difficult decisions and we did nothing. Yeah. So today I can announce that we will introduce a new sugar levy on the soft drinks industry.
So that was George Osborne speaking in 2016. The measure was implemented in 2018. So 8 years on, we can now ask the question, did that measure work? I was part of a team that helped evaluate the impact of the levy. And this question about what works is always one that intrigues me, as the definition of success or what works is often different to different people. So I'm going to start by presenting what we would call a logic model, a very sort of simple model talking about how we might expect this tax to play out. So the levy is introduced, and then the idea intention was that rather than increasing the price of drinks, it would encourage manufacturers to take sugar out of the drinks. And then assuming children, and it's mostly children who drink sugar in soft drinks, or certainly in larger volumes, would consume less sugar, and that in turn would lead to improvements in health, particularly or principally children's health. So what happened? What did we find? So first off, were the drinks reformulated? Yes, they were. So the red line here is drinks that were eligible to be taxed, and drinks were taxed if they had more than 5 grams of sugar in them. So if they reduced the amount of sugar in the drinks and brought it below 5 grams, the manufacturers didn't have to pay any tax. And we can see here, when the levy was announced, around 50% of these drinks were going to be subject to taxation, but a lot of reformulation happened such that less than 20% of drinks were actually taxed when the legislation was implemented in 2018. The blue line here is what we call a control group. So those are similar drinks, fruit juice and milk-based drinks that were not subject to tax. And we see how they haven't changed, which kind of reinforces the message that it was the levy that caused this effect as opposed to something else. Now we went a step further, and we've been able to look at what's happened to the sugar that people have brought home into their house that they've been purchasing in sugary drinks, and also the sugar in the diet, and seen that both of those have reduced. And then we've also been able to go a step further and and we've quantified the impact, this is the observed impact on children's health. And we've seen beneficial changes in dental caries, childhood obesity, and asthma that, using robust statistical techniques, we can link to the introduction of this tax. So I've outlined there a relatively simple linear model and assumption as to how this tax may play out. In reality, when we were planning the evaluation, we had a much more complex model. We had a systems model, and it looked like this. And you're probably going to struggle to see the detail, and don't worry too much. My point is just reality can be much more messy, uncertain, and ultimately complex, or possibly complicated. And what we're trying to do here is sketch out both the intended and unintended consequences, the beneficial and potentially harmful consequences. And we're also looking across a range of things. So we're trying to understand what might happen to industry. And if it was a negative impact for industry, what might that mean for employment? Unemployment has negative consequences for people's health, for example. How might the industry adapt? Would it use other measures to try and push the sale of sugary drinks, which would undermine the impact of the legislation? How would politicians and public react? Because that was important for whether the policy was allowed to persist. And it might influence whether similar policies might be permitted in the future. And during the last 10, 15 years when I've been working in this field, what I've noticed is there's been much more a shift away from more simple reductionist linear models to this systems approach and understanding and acknowledgement of complexity when evaluating interventions. Commercial. What do I mean by commercial factors? Well, let's imagine it's a Friday night, you've been out for a meal, you're no longer hungry, and you're off to the cinema. You buy your tickets, and then you're directed past the stall selling popcorn. Do you buy the popcorn? You can smell the popcorn, and it smells good. Do you buy the popcorn? Your partner tugs at your elbow. The extra large size, labeled sharing size, is on a discount. Do you buy the popcorn? So eventually you give in. You buy the popcorn, then you remember how salty it tastes and how thirsty it left you last time. So you also buy the discounted extra large bottle of soda. Now, my point here is that commercial companies know how to push buttons and children's buttons to sell their products. They deliberately arrange the layouts of stores and use other tricks and cues to influence our purchasing decisions and ultimately what we put in our mouths. And so, of course, in doing so, what they're trying to do is maximize their profits, as we would expect them to do, but they will not be optimizing for children's health. The commercial factor I want to focus on in this section is advertising. And I bring this forward partly because a number of local authorities have been bringing forward legislation in this space, but also because there is legislation on the books due to be implemented in October 2025 that will restrict the advertising of less healthy food on TV, on demand, and online. So one question that comes up is, does this advertising really matter? To answer this question, I think we need to think through what advertising is trying to achieve, and particularly what it's trying to achieve or may be achieving with respect to children. I think the first thing is social norms. So something about trying to set social norms and expectations amongst children as to what is normal food or healthy food or even good food. And what we notice is the food that is advertised is very, very skewed in a particular way towards less healthy food. Only 2.5% of the advertising expenditure, for example, goes on fruits and vegetables. Now, I would suggest if we were to compare what is being advertised to the makeup of a healthy plate or a healthy diet, it would be very different. And this is what I mean about shaping the social norms. Secondly, there's something around brand loyalty. And I know how advertisers are working or appear to be working very hard to persuade children to buy their products. And some of this advertising seems very, very much deliberately and intentionally targeted at children. One thinks of smiling tigers and smiling monkeys and how they shine brightly in young children's minds to sell sugary breakfast cereals. And of course, children, particularly younger children, but even older children, as I've alluded to in a section on adolescence, will be much less aware of what's going on with this advertising, what it's trying to achieve, and have the ability to resist or recognize it for what it is. And then thirdly, advertising also seeks to directly influence impulse buys and consumption sort of in the moment of sort of seeing the advertising. Now, all of these things are really hard to measure from a scientific perspective. And And maybe that doesn't matter, but sometimes measuring these things is important, particularly if we want to try and quantify the impacts on children's and indeed adults' health. And sometimes this becomes very important. For example, when the government was wanting to, or going through the process of making a decision about whether and what form of advertising restrictions to implement, it undertook a cost-benefit analysis. The advertising industry and elements of the food industry were very good at coming forward with their evidence and impacts as to how it would affect their industry. And it was more of a challenge to do this, but there was a real need to do it in the health space. One thing my colleagues and I were aware of was a relatively strong evidence base showing that how, when children watch advertising on TV, that affects what they consume, either whilst they're watching the TV or when they have the next meal. And it was possible to quantify the effects in terms of the additional calories consumed and the types of food that children would be consuming when they were during or after watching those TV programs with advertising. And then we were able to scale up those estimates to quantify the possible or potential impacts of removing all of that advertising from children's TV on children's health. I was subsequently able to talk to government officials, talk them through our work, and my understanding is that some of the work we did and thinking behind this, they were able to take and feed into their impact assessments, which were able to inform the government's decision to bring forward advertising restrictions. Now, taking a slight sidestep, but sticking with this theme around advertising, I mentioned systems and adaptations, or how industry may respond to new policies coming forwards. In 2007, the government prohibited the advertising of less healthy food, either before, during, or immediately after children's TV programs. This policy was evaluated by Jean Adams and colleagues, and they found advertisers obeyed the rules, did what they were supposed to do. However, they found that children, by and large, were seeing the same amount of unhealthy food advertising. Not only that, adults were actually seeing more unhealthy food advertising. So what had happened? The advertising had shifted away from children's television programs to family television programs, which children still watch in large numbers. Now, in presenting this, I'm not trying to argue that advertising restrictions will not be helpful. But what I am suggesting is there is a need to be for careful thought when designing these interventions. But more specifically, this highlights the need for robust and independent evaluation, looking both at intended and unintended consequences, benefits, and harms. Some people are sometimes under the impression that my role as a public health academic is to prove that public health policies work. I don't agree. I think sometimes the most valuable contribution I and my colleagues can have is actually showing when things aren't working. So things can be changed and adapted to get a more favourable response. And indeed, it's worth noting that the next iteration of advertising restrictions, which are due to be implemented in 2025, would appear to have learnt from some of this research, and they seem to be framed in a very broad-based way and encompassing multiple forms of media to mitigate and reduce the opportunities for advertising being shifted to other spaces. And finally, we come to environmental factors. The physical environment is important, particularly for children's opportunities to be physically active. And here I'm thinking particularly about walking. Walking is a much undervalued activity. Let's look at how things have changed. And this is a story of 4 generations of one family living in Sheffield and nearby areas. So first up is great-grandfather George. He was 8 in 2019, and he was allowed to roam over this entire large area here, including this 6-mile walk from his home to the Rother Valley to go fishing. Grandfather Jack was a bit more constrained. He was 8 in 1950. He was allowed to walk a mile to the woods, and this was the area he was allowed to roam through. Mother, Vicky, she was 8 in 1979. her freedom had been curtailed yet further to around half a mile to walk to the local swimming pool. And the youngest son, who was Ed, who was 8 back in 2007, he was only allowed to walk for 300 yards to the end of his road. So this, for me, shows how things have changed over time. And we'll probably all have our own ideas about why that may have happened. For example, rising use and dependence, dominance of cars in towns, but also concerns around children's safety. Now, I'm going to show a different comparison, not one over time, but one between places. I'm going to compare the UK and Switzerland. Now, when we're talking about children's independent mobility, we often tend to compare ourselves to the Netherlands or Denmark and focus on cycling. But as I say, walking is a much undervalued and underappreciated activity. So I've chosen Switzerland. And I think what's interesting about all of those European communities, they've faced the same challenges that we have in the UK, but they've chosen a different response and ended up in a different position to where we are in the UK. So let's just look at the picture on the left. And what we notice here, children walking to school, great. They are wearing high-vis jackets and they are supervised by adults. And my question or challenge here is, if the aim is to embed walking as something we value, that's enjoyable, that's healthy, and it's safe, are we going about it in the right way if we're putting children in high-vis jackets and insisting they need to be supervised by adults? On the right, we see the Swiss approach. Children of a similar age walking unsupervised. Switzerland, I find this staggering, at the age of 4 years, when children start school, they will be expected to walk independently to primary school and back again at the end of the day. Now, there is an awful lot that Switzerland does to achieve that. And there is a very strong culture around the value of independence of walking and child independence at an early age, embedded in the Swiss culture, that enables that to be achieved. And in so doing, they recognise and get multiple benefits, not just child independence, but also community safety and community cohesion. I find it noteworthy. There's been a lot of debate in the UK media around measures such as 20-mile-per-hour limits, which have been brought in Wales, low traffic neighbourhoods, which we've seen in parts of London and other parts of the UK. And the framing of those, to my mind, in the media is very much focused on how that's been impacting adults and people when they're driving cars. And there seems to be much less consideration of what this means for children. I wonder how those debates and discussions would play out in a culture like Switzerland, indeed, whether there would be any debate or discussion in Switzerland around measures like this, or whether they would just get on and do them. So there are things that local authorities can do in this space, tools, approaches and policies to create those safe and attractive spaces for children to be active near to where they live, be that playing, be that going to school, be it seeing their friends or going to the park. So finally, moving on, concluding thoughts. So to summarise, to tackle obesity effectively, governments should think much more about the environment and context that shape children's choices and opportunities, and put less focus on personal responsibility, parental responsibility, willpower, or individual treatments. I think there's something also about dose. And even when I've shown improvements in health here, whilst valuable at the population level undoubtedly, they could be framed or seen as small or modest in compared to the scale of the challenge we face or where we have come from. So to see the dial really shift, I would suggest we need a much greater scale and intensity of action than we have seen so far to date. Now, I'm going to caveat that with 2 things. And the first is we do need to acknowledge this will take time. 1962, the landmark report Smoking and Health was published by Royal College of Physicians. Society has come a long way in the last 60 years since that report was published. Most people living then could not imagine the world we live in with respect to smoking or its absence. And then secondly, I think a lot of that change and that change in the early stage really needs to focus on culture change and systems change and changing the social norms. and valuing those for improving many different facets of health rather than just for tackling obesity. There is a risk of focusing too much on obesity simply because it is easy to measure. And in the early stages of making meaningful efforts to tackle obesity, those levels will not change or shift at all. Now, as much as I value research, I will also acknowledge and strongly emphasize that governments cannot do, should not do just what the evidence says works. There is a need to do the best way to grow the evidence base is to do new things and to evaluate those things in a robust fashion. And in so doing, governments need to get more comfortable with and accepting of failure. Indeed, I think we shouldn't see it as failure. But that is okay because learn and do things differently. So I just wanted to finish by thanking Public Health Voices for inviting me to talk today. I want to, there's many people that have informed my thinking in this space over the last 15 and 20 years, too many people to mention here, but I wanted to mention two names in particular, and that's Denise and Lavu and John Riley, who are both members of my group, who for their kind and generous support in helping me pull the presentation together. And then I've just put up there some additional resources which people may find interesting if they want to dig into some of these areas in more detail. Thank you.
Thank you, Ollie. That was an absolutely fantastic and very, very thought-provoking talk. I'd like to move on to some of the questions now, because there are quite a few that have been coming through. So I'm just going to take them in order. The first is that people would be very interested to hear your thoughts on very high levels of sweetener intakes we're seeing, potentially partly as a result of the sugar levy, so reducing sugar intake in soft drinks.
I'm on mute, no, I'm not. So I haven't seen the data. I partly come back to some of the studies that were done before the soft drinks industry levy was implemented, and a couple of randomized controlled trials comparing artificially sweetened drinks and sugary drinks, and they showed very clearly that sugary drinks were associated with increased risk of excess weight gain. There is an ongoing debate about role of sweeteners, and I think that's a legitimate one, an important area of concern. My preference is that children should be drinking water, you know, if we can move to that stage, so much the better. And I think one of the things that's possibly being undervalued and underappreciated from the sugar drinks industry levy and all of the consequent public discussion about it, because there's a lot of talk in the media before it, a lot of talk afterwards, is just the awareness raising of sugar and its influence and impact on children's health and well-being, and in so doing, influencing individual parents' choices and behaviours.
Mm-hmm. So more data is needed.
As any good research would say, Claire.
Of course. And then, so outside of taxing sugar, stroke calorie-rich food and beverages, what are your thoughts on how we can bring the cost of whole foods, fruits and vegetables down?
It's really tricky, isn't it? And we haven't really explored some of these issues around cost, but I've sort of alluded to them about how there needs to be an investment to prevent in the future, and the costs and the savings aren't realised until a long time in the future. For me, there is something more fundamental about how we value food within society and culture. Now, historically, food prices, whilst they have been rising, are much lower or take up a smaller proportion of disposable incomes than they have done. And I think the reality is to move to a healthier food system, both from an environmental perspective and a health perspective. It probably does mean a change in the food prices. Now, how that's funded is maybe an open question in terms of the levies and subsidies that go into the food system. So I'm not necessarily saying that it will need to map into the food prices that customers will pay. But these are very important and fundamental drivers in terms of what's happening.
Mm-hmm. How can approaches that move away from traditional childhood weight management services be encouraged or supported using the evidence?
That's a really good and nutty question, isn't it? And I think it's something we feel quite a lot at the local level. And I think one of the challenges working at the local level is the levers that you have. And, it feels like you have a clear responsibility to help individuals needing and wanting help. And there's a budget to fund child weight management services. Not all areas have that, but many areas do choose to spend some of their weight management budget on children's services. So I think one approach we've tried to take is to try and shift some of our headspace and time that we spend in those areas. So free up some of the capacity in terms of managing and running those services to focus in some of those other areas, because a lot of the actions that need to happen in terms of systems change, some of them don't actually involve spending money, but it's galvanizing the system, it's bringing partners together, it's looking at what the evidence is, it's maybe looking at what kind of policies or practices can change, what can you do around commissioning services, procuring food, for example. Some of it does require money. You look at what London's been doing around children's food and lunches, breakfast clubs, for example. So it is difficult, but for me, one of the critical things is to try and free up some of that headspace to move some of that intellectual resource and time away from the focus on weight management towards broader approaches to prevention.
Okay. This is a very interesting question, very tricky one. If you were advising the CMO on the next 3 policy priorities for a new government, where would you focus?
So there was a time in my life when I did have to advise the CMO, but I never used to get asked questions like that, Claire. CMOs tend to know their own mind very well. In some ways I draw people to the report I helped Dame Sally Davis with, Protecting Children's Rights, Why Governments Must Be Bold to Tackle Childhood Obesity, which I helped Dame Sally edit. That came out in 2019. And that kind of set out the sort of responses and pattern of responses to tackle childhood obesity, alongside making the case for action. But you've asked a slightly bolder and different question, which is, I think, was priorities for children's health, didn't you?
Yeah.
And for me, I think there is this dual priority around tackling obesity and tackling mental health. And so I think I would be looking for smart interventions that can leverage both of those. I think there also has to be a balance between doing things that may involve some investment of money and things that may be more passing pieces of legislation, which may be in that more edgy area where it feels like it's restricting. I don't think it's necessarily restricting individual or children's liberties, but it's restricting commercial liberties and abilities to market or sell things.
You're probably going to try and give a broader answer to this, but if I were to pin you down and say, what might that type of policy look like, would you be able to give a kind of a concrete answer, linking up mental health and obesity prevention, for example?
I read around what Switzerland's done around children walking to schools. Now, we just cannot comprehend that in our country. But if you see what Switzerland has done, so that is enabled by the police will come out on the streets. Do you want to have community volunteers coming out in the streets for the first few weeks of school to support and enable children to do it? Drivers are educated. It'll be part of their assessments and exams around how to drive near schools. They will build their roads and street systems, I assume, in different ways near schools to enable that to happen. And that is something that if you create those kind of safe spaces for children to enjoy that walk to school, where it's not polluted, it's not congested roads, it's not noisy, it becomes a pleasant walk to school with their friends. They have a sense of pride and independence, and this ability to be independent, enjoy that independence, and grow up with a degree of freedom without adult supervision may also be important for children's mental well-being and development too. So could you do a pilot or something like that in a particular area? And I think that would be how it'd have to start.
Okay, fantastic. Moving away slightly to a sort of infancy perspective, people are interested in how much of an impact bottle feeding has on childhood obesity risk and increased weight gain compared to breastfeeding. So I mean, there's obviously a difference between bottle feeding and formula feeding. So maybe perhaps focus on formula feeding. And they specifically talking about formula as a UPF.
Claire, I feel this is more in your area of expertise than mine. What are
Yeah.
your thoughts?
Well, my thoughts are that there may be something to do with the type of milk that's in the bottle, so formula versus breast milk, but also the act of bottle feeding versus feeding directly from the breast. It's one of those areas that actually hasn't brought as much clarity from the evidence as we might hope. So the large randomized control trials of the breastfeeding promotion interventions, such as in Belarus with 16,000 infants. The intervention group who were randomized to have breastfeeding promotion and support, and vast numbers more breastfeeding to 3 months than in the control group. There were no differences in overweight and obesity in adolescents. But the observational studies show that there is an important effect, and it might be that it's diluted in the trial. So I think it's a very difficult question to try and unpack with the evidence. My thoughts are that we need a lot more support for breastfeeding in the UK, whatever the evidence is saying, and I think it's very clear on things like infection. And I think there's a lot of interest in optimizing formula to ensure that it is a nutritional and safe option for babies who are not being breastfed. That's as much as I'll say on that.
It sounds very sensible. And the Belarus study I find interesting because I've heard suggestions the context was different, and the economic drivers were different in Belarus, such that parents may have been much more sparing with their use of formula feeds in the Belarus setting than they might be in a Western setting. But I think there is something important. My understanding of the literature is it is partly how parents feed and some of those social expectations and norms around feeding. And that would apply whether it is express breast milk in the bottle or it is a formula feed.
So responsive feeding being really key.
Yeah.
Also the guidelines being adhered to by the products, I think, as well.
Yes, and it is noticeable that the guidance changed, but it was a delay between those changed feeding volumes being reflected on the packets of formula feed. I believe they are all correct, and they've had a long time to update.
Yeah, they vary enormously. So Raj and Kenong and I had a look at those recently, and they're still some of them are very out of whack with what's recommended.
Okay, interesting.
I'll move us back to the other questions because there's a few more to get through. So should the soft drinks industry levy be upgraded, e.g. taxing sugar more or including non-nutritive sweeteners, and what learning might apply a similar approach to other foods and drinks?
I think it's somewhat difficult because the soft drinks industry levy was very carefully and thoughtfully designed, and there was intention to put the levy on manufacturers and encourage reformulation. Rather than, as people had assumed, it would be about increasing the price and discouraging consumption that way. And there's a question in my head to what extent you can do that. If you reformulate a chocolate bar and you take the sugar out, what do you put in its place, for example? Because sugar fulfills other things, it's some of the mass and volume of the product, for example. But I'm not a food scientist. So number one, I think that was in a special place. In terms of going more broadly in terms of food, it is very difficult in the present economic circumstances, I think, to countenance raising food prices through taxation. I wonder if some of the smarter opportunities in learning in terms of the levy are around placing some of those taxation measures earlier in the food chain. There is a very nice article that I wrote with Emily Aguera and Pablo Monsievis, which was published in the BMJ several years ago. We looked at how food subsidies had impacted on what was being produced, because food subsidies. So food subsidies had changed how the market was behaving and produced. It had favoured particular areas of the market. So it favoured, for example, sugar beet production and sugar production, in such a way that the industry had now got itself to a state where it was a very efficient and large producer. It had a small number of large and efficient producers, and it was in a very strong and dominant position and could churn out sugar at very cheap prices. So there is something about how historically we have used those subsidies that have probably got us into a difficult position. And there was a question in my head about how we might use those subsidies going forwards to incentivize parts of the industry which are helping the promotion, production, and sale of healthy foods, or having a balanced tax and subsidy approach, so taxing some aspects of the industry, but giving subsidies to other parts of industry. And I suppose what I'm saying is, I think there's a fairness or legitimacy argument for doing that, not just in terms of the environmental and health benefits and consequences, but also in terms of fairness, in terms of what's happened over time and how historically certain industries were favoured.
Yeah, and this is a slightly related question, actually, which is with such a strong association between obesity and deprivation, it's imperative that healthy food is subsidised. And how do we achieve that? And you talked about the cost of living crisis at the moment, and there's higher levels of food insecurity than there have been over the last 10 years. So,
and more use of food banks.
Exactly. Are there things that can be done? And what would that look like in terms of a policy?
I mean, I suppose the obvious one is the sort of Healthy Start voucher scheme. So this offers credits to families of young children on lower incomes with the intention that they are able to buy healthy products. Historically, I think that program's always had some challenges. It's had challenges around sort of social acceptance and some kind of stigma associated with the program, as it's only offered to certain groups in society. And then I think there's also been sort of like access issues, like vouchers being sort of difficult and cumbersome to use. There's obviously a tension. There's a huge tension and challenge here, isn't there, between like targeted interventions, which are seen as more cost efficient but can be stigmatizing, versus going for something which is universal and in some ways feels very kind of justifiable in the traditional post-war approach. And justifiable in the sense that all children should be benefiting from these things and removing stigma. But in present financial circumstances, that feels increasingly kind of hard to justify. And if you look at the costs of food, you look at the costs that London, for example, is putting into school meals for children, those are big costs, and sustaining those over long term is hard. I think it's going to need some there's a really interesting question for some of the health economists here to look at how and where those benefits are realised in the system. And I do think there is a danger in some of these spaces, youth clubs being one, for example, with we stopped spending on youth clubs and clubs around schools and things like this. And that has multiple detrimental impacts in terms of children's ability to socialise, have safe spaces, be physically active, it protects against bullying. And a lot of these things are sort of in some ways coming back to affect us. And I think we're seeing and there is that danger of being very short-sighted with some of these decisions about what we cut. But yeah, economics is hard, isn't it?
It is. There's one more question which you can give a this or that answer to, which I'm just going to quickly ask. We've got time for one more. What do you think has more of an impact on weight, calorie intake or physical activity, particularly for weight loss?
I think the first thing says for children, the aim is rarely weight loss. It is growing into their weight. And children should not be advised, by and large, unless under medical supervision, to be on weight loss diets. So it's more a question for adults. And the evidence there would suggest that calorie change and reduction is more important. However, physical activity has a very important role in helping people keep off that, keep the weight off once they've lost weight. Maintain
a healthy weight. That's wonderful. I think at this point, I might close up and say thank you for a really, really fantastic talk, Ollie, which in 40 minutes managed to include social factors, political factors, economic factors, environmental factors, and you even touched on genetics as well. It's very clear there's a long way to go. This is an incredibly balanced presentation of, policy implications and the evidence so far. And thank you ever so much for taking the time to present to everyone and answer the questions so helpfully. Thank you. And thank you everyone for attending.